So I'll go ahead and start recording and kind of officially welcome everyone. So welcome to Innovations in Community Care. It's a 10-week series of brief talks on important topics in community medicine. My name is Dr. Lawrence LeBeau. I'm the program director for the Wright Center for Graduate Medical Education National Family Medicine Residency Program that organized this event. The speakers that you're going to hear from each week are faculty members from one of our training sites. I say one of our training sites because our program is the only national consortium of teaching health centers that have come together to form one ACGME accredited family medicine residency program with osteopathic recognition that operates as a single program with training locations in 4 different states. Our community health center partners are El Rio Health in Tucson, Arizona. We have HealthSource of Ohio in Hillsboro, Ohio, HealthPoint in Auburn, Washington, and Unity Healthcare in Washington, D.C. If anyone's interested in learning more about our unique, innovative program model as a whole, or one of our residency training sites in particular, we'll give you the opportunity to meet with faculty and residents at the conclusion of tonight's talk. But recognizing that everyone's time is valuable, we want to keep each talk in this series both high value as well as brief and to the point. So with that brief introduction, I'm going to hand things over to Drs. Will Dixon and James Huang from our Unity Healthcare partner site in our nation's capital to kick off our series with their presentation tonight on the value of POCUS, or point of care ultrasound, in low resource settings. Dr. Dixon, I'll turn it over to you.
Thanks so much. So can you guys see my slides now?
Yes, they're not in presenter mode, but we see them.
All right, off we go. And Dr. Huang is actually going to start us off.
Great, thank you for that introduction. So we're here to talk about the exciting potential of POCUS, or point of care ultrasound in low resource settings. And we can go to the next slide. This is just a kind of like a snapshot of the history of medical ultrasound, kind of used by cardiologists beginning in the 1960s. But then, as you can see, over the years, different specialties have adopted using ultrasound in their care for patients. And you can see that eventually, as we move into the 2020s, that all providers are using ultrasound is being used in different settings. And we are here to talk about how POCUS is used in our primary care setting at a community health center. The next slide. And so here you can see kind of like the different applications for POCUS. So we can use point of care ultrasound for evaluating lymph nodes, making sure someone doesn't have pneumonia, evaluating someone for right upper quadrant pain to see if they have gallstones. We can evaluate a patient coming in to see if they have pyelonephritis. So there are really many different applications that we can use in the outpatient setting. And that's high value and low cost. So, back in the day, probably in the 1960s, when the cardiologists were using, this is what the ultrasound machine looked like, big and bulky. But really, with the advent of like machines like the Butterfly, what you can see in the right-hand corner here, it's really been easy for us to incorporate it into the outpatient setting and made it much more accessible to all of our patients.
All right, so I'm going to take over and talk a little bit about how point of care ultrasound is really improving care for our patients in community health centers specifically. And so it's a pretty exciting modality because it's allowing us to move things from the hospital setting to the community health center. And there's sort of 3 discrete ways in which we really feel this is benefiting our patients. The first of those ways is that it's giving better access to specific screenings. The second is that it's helping us to provide better procedural care. And the final way is that it's reducing our barrier to diagnosis of different things. And we're going to go over a few ways how at the Wright Center's National Family Medicine Residency Program in DC specifically, we are sort of helping our patients through each of these different ways. So the very first one that we'll talk about is improved access to screenings. So many of you are probably familiar with the U.S. Preventative Services Task Force recommendation as far as it relates to AAA screening. So there's good evidence that if we start screening men ages 65 or older, we can generate a 35% reduction in AAA related mortality. So that's amazing, and tons of our patients fit into this. So it's 65 years or 65 to 75 who smoke is the people that are specifically targeted by this recommendation, which is a ton of our patients, and very, very few of them get screened. There's a lot of barriers to access. It includes insurance coverage. A lot of our folks are underinsured who do not have insurance and therefore never make it to see the radiology departments at various hospitals. There's transportation issues, and there's just so many different things that mean that our patients are generally not meeting this requirement. However, with point of care ultrasound, we're able to do those screenings right in clinic. And so debuting this year, we are doing our point of care ultrasound screenings using our butterfly probes directly in clinic. So here you see an abdominal aorta. That's this big black mass right here above the vertebrae right there. And so this is just one of our patients who is being screened directly in clinic. So no need to go into the hospital, no need to coordinate insurance, no need to coordinate transportation. This is a screening that can just be done right at the bedside. Here's that patient's aorta being measured, and you can see that they're underneath that 3 centimeter threshold. So we know that this person does not have a abdominal aorta, at least in this particular view. Here's another quick glimpse of going down to the iliacs. We've measured the iliacs here, and so we can see there's no aneurysm in the iliacs either. And so this is a patient who, we've managed to complete the AAA screening for right in clinic and decrease their burden of having to get across town to get the screening. The second way in which point of care ultrasound is helping us to provide better care to patients is helping out with our procedural care. There's a lot of different procedures where when you're doing them in a community setting, you end up doing it with fewer resources than folks in a fancy private clinic might have. So here's a ganglion cyst there. I'm holding the ultrasound over, and here's a resident who's a needle is appearing in the middle of the ganglion cyst. And you'll see the fluid quickly being aspirated out of it. And so this is something that doing blind is a lot trickier to doing with an ultrasound. You can see actually so much of the fluid had been sucked out now that my probe has lost contact with the skin. So there's a entirely aspirated ganglion cyst. And so having the butterfly and probe in clinic really helps us for a bunch of outpatient procedures, cyst aspirations and abscess aspirations and other things like that, in which we were able to direct the care a lot more specifically by being able to sort of look inside the body as we do it. And then the finest and possibly biggest application for point of care ultrasound in low resource settings is just reducing the barrier to diagnosis. There's many different things in which having a butterfly probe prevents us from having to send the patient into the emergency department or having to order a expensive scan. And so I'm going to go through a bunch of those cases right here, and we can sort of look at how having a butterfly probe benefited each of these patients. So this first one, this is actually just earlier this week. This is a 35-year-old person who came in with 2 days of upper abdominal pain and maybe some subjective fevers at home. And so this is something where we might be worried about cholelithiasis. So here's my butterfly probe on his abdomen, and I'm taking a look at his gallbladder, which is that sort of question mark looking structure right here with the dot of the portal vein down there. And I'm able to look at it. I'm able to see that there's no gallbladder wall thickening. There's no stone blocking the gallbladder. And this is a person who I now feel a lot more comfortable not having to send to the emergency department, where, he might sit for 6 hours. He might get a bill that drives him into bankruptcy. He might catch COVID sitting in that emergency department waiting room. And so this point of care, being able to have a butterfly and put it on him right there, just really dramatically improves the care I was able to give to this guy. This next patient is a 32-year-old woman who 2 weeks after delivering came in with a little bit of shortness of breath and trace peripheral edema. So she's someone who had asthma, and the provider was like, well, I think that this may just be like a little bit of an asthma flare, but in the setting right after having given birth, I'm not totally sure. Like, I'm worried that her lungs are just totally full of fluid. What can I do? And so putting the ultrasound probe off, and this is just one one thing that we are looking for in the scan, but what we're seeing here is the curtain sign. And so that's the diaphragm moving across the bottom of the lungs and back. And so that curtain sign is a ultrasound artifact, which lets us know that there is not significant pulmonary edema. And so by seeing that sign, that really excellent lung sliding right there, we could tell that at least the bottom of our lung right there is not full of fluid, and that made us feel a little bit better that we weren't missing like a massive pulmonary embolism or anything like that. This is one component of a larger exam, but you get the picture. This next patient is a 58-year-old person with pain and tenderness over his left forearm. He had recently been using IV drugs, and as I looked at that arm, I was like, oh boy, this doesn't look great. Are his tendons okay? Or is this someone that I need to be sending for consideration of like imaging in the emergency department, and possibly debridement, and possibly surgery, and to protect those tendons, because it looked pretty rough. But throwing this on there, I was able to see that the abscess, there's an abscess, first of all, that I knew that there was fluid that I can drain, and I drained it out in clinic. But second of all, I could see that it stopped short of the tendons up there. And so you can see during this video, I'm having him extend and flex his tendons to see if I can see any fluid that's passing around the tendons right there. And without any pain as he was doing that, and me being able to see that the abscess seemed to be separate from that, I felt comfortable draining him and having him follow up instead of sending him into the emergency department for more invasive care. All right, this next person is a 48-year-old gentleman who has a tender and firm periscrotal mass. So this is one where, as we were inspecting it, we weren't totally sure what we were looking at. It was pretty solid. It was painful, but it didn't have that hallmarks of an abscess. We couldn't really feel fluid inside of it, so we weren't sure if we were, whether we might be seeing something else. Putting the ultrasound on it, you could see this very clear fluid right here, and so that made us feel better that it wasn't some other sort of other mass that we were seeing, not like and that's something that was coming from the scrotum itself. You can see we're scanning left and right and making sure that it's sort of entirely self-contained. And once we're convinced it was, we could see there was an abscess, and we were able to drain it, and he walked out feeling much better. Again, this is another person who might have gone on to need a specialty referral. He might have needed to go for more imaging in the hospital. It probably would have been expensive. It would have opened him up to, both financial and medical risk of having to go to those other things. And having the point of care ultrasound probe meant that right in that same visit, we were able to evaluate it, diagnose it, and give him the treatment that he needed. And then this final one, this is a 12-year-old girl who came in with tenderness and swelling in her forearm that had been going on for 4 weeks. It was, sort of a tricky exam. It didn't look totally classically like an abscess or anything. So we put the ultrasound probe on. What we're seeing right there is in this deep tissue, there's a mass right there. It's not hypoechoic, and so we can see that it's not fluid filled, and it has this hyperemia. This is a hyperemia surrounding it, so we can see that the fluid, or that the tissue around it, is sort of filled with fluids. I'm sort of scanning up and back, and I can see each of these nodules that seem to be sort of contiguous and connected, and they're pretty firm right there, and it's tender over what she's pushing on, or over where I'm pushing. And so this is a mass that has me pretty worried. And so this is, someone who I was worried that this was a cancer, and so I sent her into the children's ED, and an MRI showed cancer. So she has a sarcoma in her muscle there. But having the ultrasound helped us to know that this was something that we had to take really seriously, that it wasn't, something, otherwise I might have thought it was an abscess and tried draining it in clinic, which really would not have been helpful, and might have led to, an unnecessary procedure, unnecessary pain for her, and a delay in diagnosis. Being able to look at this with an ultrasound helped her get her to the care that she needed, which was a pretty acute surgery to take care of this. So each of these are examples of how having ultrasound in clinic really helped out to get a patient to a diagnosis faster than they would have otherwise. Moving on to our next one right here. This is a quick video of our one of our residents, Alicia Heiner, demonstrating a DVT exam. So I'm just going to play through it really quickly because she does a really excellent job showing how you can use ultrasound right in the clinic to look for DVT. Tell me if you have trouble hearing this.
Yeah, I'm not hearing her speak at this point.
Oh, okay, that's okay. Sometimes we have that issue with playing YouTube videos. So we got really lucky with Alicia because she is was an ultrasound tech before us. But right here, what she's showing us is she's working her way through the veins of the. I'm going to mute her so she's not distracting me. Working her way through the veins of the lower leg, so we can see these two right here. So here's the vein, here's the artery. When you compress, you can see that the artery collapses there. And then she's going to work her way down the patient's thigh. Every centimeter or so, she's going to compress. And the front wall being able to touch the back wall means that there's no clot separating them. And so that's the DVT exam right there. So she, works her way down, compresses as she goes. Changes her gain, changes her depth. And every centimeter or so as she works her way down, she's going to compress so you can see the walls touch. And that's the entirety of a DVT exam. And so, when you are in clinic and see someone that you're worried that has a DVT, you're often faced with this challenge of, do I send them to the emergency department to try to get a scan there? Do I, send them for an ultrasound, which might take weeks to arrange? With the butterfly probe right here in clinic, we're able to make that diagnosis. So that YouTube video is part of a series of YouTubes that we have been trying to produce to sort of show the different exams that we can do right in clinic. I'm dropping into the chat a link to our YouTube playlist, and so you can look through each of them. Yeah, so that's a sort of brief look at some of the different applications that we've used.
Great, thanks. And so, if anyone has any questions, please feel free to ask. But basically, as Dr. LeBeau mentioned at the beginning of the talk, we're an innovative program, and one of our innovations is integrating POCUS in our residency curriculum. And so, and in DC, at the DC site, we have a monthly POCUS lab where we provide hands-on training to the residents on a particular topic each month. So, so like the next month will be something on like the FAST exam, and then the following month we might do like a DVT lab. And then we also have the butterflies at the continuity sites where residents see their own patients. So we have 2 sites, and we have multiple probes available for residents to use in their outpatient clinic when they're seeing patients. And we do, because POCUS is a relatively new to us, we do have ongoing faculty and preceptor development, not only at the DC site, but at all the sites to increase our confidence for the preceptors and attendings to use POCUS and being able to precept it and teach it at our to our residents. And so these are just some pictures of some of the preceptors getting trained, and then the residents in the Washington site, and then Dr. Dixon here with one of our residents from last year. And then here, volunteer, if there are any questions, please feel free to ask about POCUS, about our programs, anything. It's
Any questions from anyone?
I have, pretty basic. I'm from Oregon, at a community health center, which is a low resource place, not only in terms of who we serve, but our access. And so what's the cost? Both the expense for the machines, and then as well as say cost and training in order to start something like this.
Hey, Dean, it's great to see you.
Hi, Will. It's good to see you as well. Yeah.
Dean and I used to work together. So those are great questions. So the cost of a butterfly probe, we applied for grants, which helped get money for them, and begged and pleaded the right center to get them too. I think a butterfly, if I'm not mistaken, runs like somewhere around the $2,000 range, and they usually come with a subscription, which Butterfly will sell you the probe, and then usually with it there's a HIPAA compliant sort of cloud storage that comes with it. Which has been helpful for us with the AAA screening, because for insurances to pay for it, they need to you need to be able to store the images someplace, and so the being able to have that cloud storage helps with that, and so through grant money and other stuff, like it's something like $2,000 a probe. And do you recall, Larry, how much when we were paying for subscriptions, how much that's been per year?
I don't remember, because we have an enterprise account that covers the whole program. I don't know what it'd be on an individual basis, but it's about that kind of $2,000 range.
We have at least one resident who bought themselves a probe with their CME money, so it's low enough that you can do that. Yeah, definitely. When you think about how much a patient pays for an MRI, like just a scan or two it would probably be the equivalent of buying an entire butterfly probe.
And then the training for the faculty, we did it through the GUSI, so the Global Institute or Global Ultrasound Institute. I think it ranged around like $1,000 per person for like a 2-day training course, I think.
Correct. It was $900 for a 2-day, 14-hour training course.
Great.
And then the follow-up to that, for additional training, they also, the Global Ultrasound Institute is the organization we work with. They offer a year-long faculty development fellowship to continue your skills development, where they kind of support you through some online video modules and monthly 1-hour-long virtual meetings where they kind of go through your scans with you and give you tips and pointers on how to improve your technique. And that's about $1,000 for the year-long fellowship.
Yeah, and that actually leads pretty well to the next question. Raman Sami in the chat said that they've had some faculty ask how doctors can bill for these procedures. And so we are billing for our AAA screening. I forget exactly what the CPT code is, but we bill those. To bill for the other procedures that you do, our plan is to, once folks have gone through the fellowship training, then they'll, with that certification, part of the plan is that the insurers will then reimburse if you have someone who is fellowship trained. I bill for dating OB ultrasounds because I went through additional training for that. But in terms of like a point of care, like the lung scanning, the like quick that like gallbladder scan and other things like that I did, we're not billing yet. We're sort of hopeful for once we've each gone through the fellowship and are sort of signed off by the GUSI folks, we'll be able to bill for those as well. But I do sort of feel like the, as they say, the butterfly or the, handheld ultrasound is the stethoscope of the 21st century. And I think, within 10 years or so, we'll see, it will just be completely routine in medical education. And, leaving a family medicine residency and not knowing how to use an ultrasound will be the same as like not using a stethoscope. And so I think it's just something that's going to be completely routine. So we're trying to get ahead of that curve rather than catch up once it comes.
I have another question that may be of interest to folks. Can you give us some sense of what the learning curve is like, how long it takes you to learn how to do a scan, and then like to do a AAA screening? I mean, the images, it looks like it takes 60 seconds, but does it really take like 5 minutes, or in real time, what does that look like in terms of like office workflow and those kinds of things? And how long does it take to really kind of get to that point where you can do a AAA screening in just a few minutes?
That's a great question. I would say shockingly fast. I think ultrasound felt very intimidating to me before I had gone through those trainings. And I think those trainings made me realize that, with someone giving you sort of good instruction and teaching you your landmarks and sort of simple tricks, it's, I don't know, James, what do you think? How long do you think it took you to feel comfortable doing those things?
I'm still working on it.
Yeah, I
just went through the training, so yeah.
Sure. Yeah, it depends on the scan. There's definitely some scans that are like a little bit more complicated. Like some of the heart-related scans, I think probably take a little bit more practice and seeing a little bit. But like, for example, the DVT exam on like a patient with simple anatomy, it's as simple as being able to localize those vessels and seeing the front wall touch the back wall, and that's in the entirety of the DVT scan if you can follow that vein down to the popliteal. So it depends on the scan a little bit. For the AAA scan, I think that something like an N of 10, you'd feel pretty comfortable, especially with someone who really knows what they're doing instructing you. And you asked specifically about how long it takes to do one of those AAA screenings. I would say it's very bowel gas dependent. You have to. It depends like what the person is eating. Like that's often what sort of thwarts you being able to get a nice clear picture like that. But working with someone who is pretty good at navigating that, can help you figure it out. And so like with the if the bowel gas is all behaving, you could probably complete a scan in 2 or 3 minutes.
Will, and James, have you guys used these to do more procedure-based joint injections, actual like shoulder injections, hip injections, like sports medicine folks are doing, or?
Yeah, great question. I find them really helpful for sort of the old arthritic knees where the joint space is like a millimeter wide, and it's that knee where previously I would have like probed and tortured some poor person's like old knees. And so being able to actually visualize the joint space and watch the needle go into there, I think is definitely, my patients feel a lot better about it. I haven't used it as much on shoulder injections, and we had a sports medicine doc here that was using it for hip injections, but I haven't done those yet. Knees, it's extremely helpful especially for those hard knees that are hard to find that joint space.
Then I guess the last question I have, because I work for an FQHC that's self-insured. We're not under the federal tort. And so how does this play out, sort of medical legal in terms of us being considered qualified for that type of reading? Is the certificate that you all are working at or have obtained adequate?
Yeah, so I think that the certificate that we have, like when I am describing the scans, like a lot of the scans that you saw right there, besides the ones that I've been like specifically signed off for, I'm usually saying informal point of care ultrasound scan revealed, and then I describe what I have, and I'm not putting the CPT in. And it's like my stethoscope informing my practice rather than the definitive, like, rather than like the purely like the end of the diagnosis. It's part of the diagnosis rather than the diagnosis itself. For things like when I do dating ultrasounds, it goes into the computer, and because I've been signed off for them, I think that we're medically legally protected if I were to mess up somehow.
And also we explain to the patients, like Dr. Dixon saying that it's like just a diagnostics. It's like helping us kind of like make a clinical decision, but not necessarily like definitive. So that's what we're trying to explain to the patients before we do this ultrasound.
Yeah, and really we should think of all scans like that. Like many things are not like the, everything has a sensitivity and specificity. Ultrasound is like actually pretty good sensitivity and specificity compared to other things, but we should, with any scan, we should be remembering that there's a margin for error. I really appreciate the questions. These are really great questions.
I mean, it's something that we've talked about in our, group of clinics and stuff, but access to the hardware has been problematic. And then, but if we're saying $2,000 roughly for a device and $1,000 a year for storage in order to have some way of saving it. Do you ever use it, save it into the EMR? I know our sports medicine docs have tried that.
Yeah, our EMR doesn't have a great way of doing that, unfortunately. I think that there are probably other EMRs that have a slightly more functionality to be able to put it in. But for our insurers, you just have to have some place where you can show it to them if they want to confirm that you're doing the scan. So we haven't done it in the EMR. When I do OB scanning, I print out screenshots and scan them into the EMR. That's through a GE device rather than a Butterfly. Yeah, but honestly, Dean, I think that the biggest thing that you need is a champion. You need somebody who's going to take it on, get excited about it, go do one of the trainings, and then spread it to everyone else. I think it sort of takes one person in the clinic getting exciting and doing the training, and then it sort of propagates from there.
And also too, it's been helpful like on the residency side, because we've had like resident champions who've helped like integrate the POCUS curriculum into our didactics and kind of help coordinate kind of like pre and post learning like surveys of like how residents are like learning and retaining information. So that's been helpful too, that we've had residency the past couple of years kind of help be the champions at the site.
Absolutely. Yeah, having learners that are excited about it is a real joy, because they can, a resident who's really excited about it can take the program forward years if you empower them.
Thank you.
All right, folks. Any further questions? I know we had hoped that part of this would be a sort of opportunity for to split off, and so any residents who attended would have a chance to sort of meet more meet with the folks from the different sites if they had any questions for individual sites. But I don't want to cut off other questions if anyone has any. All right. Well, thanks so much. Dr. LeBeau, do we want to put the other clinic Zooms into the chat and move to that phase, or what do you think?
Yeah, I don't have them because I'm not sure that each room is manned tonight.
Okay.
As we kind of roll this out, we'll kind of learn from week to week. Right now, I would certainly entertain any questions that anyone has about the program in general and any of our individual sites. If you have questions about those, we can take those questions right now. And if not, we'll go ahead and wrap things up. It's worked out, I think, pretty well for our first attempt. Our idea was to have some really brief, focused, high-value talks in a TED Talk kind of style, just 20 minutes or so, kind of get the information out there, leave plenty of time for questions and answers and discussion. I really appreciated the questions everyone has had tonight. I think it's really been a good discussion. And if there are any other questions, we can take them right now. If not, we can end our first session, and hope to see some of you back here next week. Like I say, this is a 10-week series. We'll see what how things go from week to week, and hope to see many of you many times.
Thanks, folks.
All right. Thank you, everyone. Good night.
Thank you.